Thank you all again for the kind invitation to be back here for my second time in a short few weeks. It's an absolute pleasure and a privilege. So today, I want to talk to you about a few different things. As Praveen mentioned, my role is that I'm a cardiologist, an interventional cardiologist, meaning that I specialize in doing invasive procedures. Although my specialty or subspecialty area of interest is in performing minimally invasive valve repairs, valve replacements, and as Dr. Suri mentioned, placing devices in the heart to minimize the risk of stroke. And so that's what I want to focus on today, and try and share a little bit of a flavor of where we're at now in terms of modern medicine, particularly as it relates to cardiology and some of the offerings that we have at Stanford. So today I want to touch on the basic anatomy of the heart, just to orient everyone to what we'll be talking about. Talk a little bit about atrial fibrillation, which Dr. Suri mentioned is an extremely common condition affecting patients, particularly as they get older, and how we can help prevent strokes with novel devices. The concept of hole in the heart, or a PFO, or patent foramen ovale, and how closing these can also help prevent strokes. And these have been part of recent changes to the guidelines for treatment of these patients. And then finally, to talk about valvular heart disease, which is an extremely common and somewhat under-recognized problem in society, particularly in elderly patients, and talk about how there are a number of alternatives now of minimally invasive approaches compared to traditional open heart surgery. And so just to orient everyone, obviously there are different levels of medical understanding. The heart has four main chambers, the two upper chambers, the atria, and the two bottom chambers, the ventricles. There is the right side of the heart, which you can see here depicted by blue, and that's where all the veins from around the body converge and return blood after the tissues have taken oxygen out of it. They get pumped to the lungs, where oxygen is put back into the blood, and then return to the left side of the heart, whereby the heart pumps and squeezes it to the rest of the body, to the brain and all the other vital organs. Now, in addition to all of these four chambers, there are four important valves, just like valves in any sort of plumbing system, which allow the passage of blood forward and, when healthy, prevent the leakage of blood backwards. And those four valves are at the interface of all of the chambers and the large pipes that lead either to the lungs or to the rest of the body. And they are the pulmonic valve, which separates from the right side of the heart going to the lungs, the tricuspid valve, which is between the upper and lower chamber of the right side of the heart, the mitral valve, which is between the upper and lower chambers on the left side of the heart, and the aortic valve, which allows blood to pass through to the rest of the body. And so some of these terms may be familiar to any of you who have either yourself or through family members encountered any disease states of any of these structures. So now the Watchman device is an interesting device. This is for patients with atrial fibrillation. So atrial fibrillation is a very common condition, particularly as patients get older. Those patients that have congestive heart failure, high blood pressure, age over the age of 65, diabetes, and females have a higher risk of developing a stroke when you have atrial fibrillation. This device is called a Watchman device. And there's a new version of this device, which we have at Stanford, which is a device that we implant through a minimally invasive approach, through a vein in the leg, and attempt to put it into the heart to reduce the risk of stroke. The advantage of this is that once implanted successfully in over 90% of patients, there is no longer a need to take blood thinners in order to prevent the stroke. And that's very important for elderly patients who are at high risk of bleeding, whether it's because of impaired kidneys, because of frequent falls, or simply because of advanced age. So what you see here is this area called the left atrial appendage. And because of low blood flow, blood clots can form in that area. And those blood clots can migrate to the brain and catastrophically cause a stroke. So this procedure is done under general anesthesia, typically under an hour, and the hospital stay is 1 day. In our experience at Stanford, the procedure time is about 30 minutes, and I actually discharge the patients the very same day, so it's a day procedure. I navigate through a little incision in the vein up to the right side of the heart, as you can see here in this animation, and then making a very small hole from the right side of the heart, crossing into the left side of the heart. We advance a catheter over very small wires. So this is in complete contrast to any open heart procedure. Through these little catheters, we're able to navigate into this pouch called the appendage, where a lot of these clots reside. And then very carefully, we place this Watchman device, which you can see there, basically blocks off or occludes that area. The device grows over with the heart's healthy tissue And what that means is that there's now a mechanical barrier to prevent those clots that form in that area from shooting out and potentially going to the brain and causing a stroke. So you can imagine that this has been a significant advantage for patients. You need to stay on blood thinners for just 6 weeks. And after that, all you need to take is a baby aspirin lifelong. And it's a very safe and effective procedure. So it's been around for a long time, since 2005. There have been multiple clinical trials performed. And in all of these trials, they've had excellent clinical outcomes, excellent safety profiles. As I said, the procedure now takes about 30 minutes in experienced hands, and we're sending all of our patients home the same day. It's successful in over 90% of procedures, and most patients, I would say above 95%, are able to come off their blood thinners after that 6-week period. What about patent foramen ovale, otherwise commonly known as hole in the heart? Well, this is a very common condition. When we're babies inside our mother's fetuses, it's actually normal to have a hole in our heart because our lungs aren't mature. And so we rely on our mother's circulation to provide oxygen to a baby. And so that hole in the heart is actually a protective, appropriate mechanism. Once we're born and our lungs start to mature, that hole should close off. However, in 20% of patients, that doesn't occur. And so you have what is called a patent foramen ovale, or a hole in the heart that remains. Now, it's very common, so 20%, so 1 in 5 people walking around actually have this. In the vast majority of patients, this won't cause any issues at all. And a lot of people don't even know about this. It's an incidental finding. However, under certain conditions, the flow of blood can change such that blood flows through this hole from the right side of the heart into the left side of the heart. Now, why is this a problem? Well, if we develop any sort of clot or foreign material, air, fat, or blood clot on the right side, and it passes through that hole to the left side, remember that left side, when it squeezes, pumps blood to the brain and to all the other tissues. So what can catastrophically happen is some of that foreign material can go to the brain and cause a stroke. Now, previously, if a patient had a stroke with no other cause identified, and in the part of the workup by the doctor, they were found to have a PFO, they were placed on blood thinners in the hope that they wouldn't have a stroke again. If, despite being on blood thinners, they had a recurrent stroke, then the suggestion was to go ahead and close that hole. Well, fortunately, the guidelines have now changed to say that if you have a stroke and there's no other clear cause identified, and the only thing your doctors can find is this hole in the heart, then it is recommended to close that hole. Now, the good news is, again, in experienced hands, this procedure can be done very simply and very effectively in a matter of under 15 minutes. So this particular device is the device that I use in 90% of patients. It's actually done consciously under sedation with just local anesthesia. A wire is placed crossing from the right side through that hole to the left side of the heart. And then a device which consists of 2 discs is placed, 1 disc on the left side of the hole, pulling back to seal that hole, and then another disc on the right side. This procedure literally takes me between 10 and 15 minutes. As I said, is done under just local anesthetic with mild sedation, and is a day procedure, meaning after resting for a few hours after the procedure, the patient can return home. You remain on 2 blood thinners for a month, and then thereafter, as the device grows in and becomes part of the heart, just a baby aspirin for the rest of your life. And you can see there with that device closing that hole in the heart, no longer can any clots get through that hole, therefore preventing the risk of a recurrent stroke. Moving on to another area which is also important, particularly as patients get older. So there is a gamut of valve disease, as one can imagine. As I mentioned, there are 4 valves in the heart. I'm going to focus on aortic valve disease, just again, to give you a flavor. It would be too exhaustive to go through every valve and every disease, but just as an example, and this applies to all of the valves, valves can either be narrowed or leaky or a combination of both. Perhaps one of the most commonly understood disease states is something called aortic valve stenosis. So the aortic valve, as a reminder, is the valve that leads from the left side of the heart when the heart squeezes and pumps through the aortic valve, and blood goes to the brain and the rest of the body. So it's a very important valve. A healthy aortic valve has 3 components to it, kind of like a Mercedes sign. And these 3 leaflets open to allow blood to go through, and then close to prevent blood leaking backwards. Now, what happens over time with age and degeneration of the valve is that calcium builds up on the valve, and it becomes very stiff and very restricted. And so you can see here that the valve clearly looks much more diseased compared to the normal healthy tissue. But importantly, the valve, when it's diseased in its restriction, is no longer able to open. And why is that important? Well, it's because when blood tries to be ejected from the heart and pumped around the body, it can no longer be ejected in the same way through this narrowed, restricted valve. And so less blood is going to the rest of the body, and importantly, less oxygen is being delivered to all of the vital organs. And so patients may present with a combination of symptoms, which can include, but not limited to, fatigue, shortness of breath, chest tightness, dizziness, or passing out. And it's a very common condition, particularly in patients above the age of 75. Approximately 8 to 10% of patients may have this disease. Now, previously, open heart surgery was the only way to treat these patients. And as you can imagine, open heart surgery is very invasive. There are a lot of risks associated with it, particularly in elderly patients. And it's associated with a prolonged hospital stay and a prolonged recovery, naturally, when you're cutting through the chest bone. Now, what's been a marvel in modern medicine is to be able to replace a valve through a small incision in the leg with the patient awake, not under general anesthesia, but with sedation. We pass a wire through the diseased valve. We balloon it to help open it up in some instances in case it's very stiff. And then after we balloon it, the valve starts to open up a little bit more. We remove the balloon. And remember, this is all done through the artery in the leg, through an incision that's less than 1/3 of an inch. We then place a brand new valve through a small tube, through that small incision in the leg. These valves, there are different types available on the market. This valve that's being depicted in this animation here is the valve that I use in over 90% of my cases. And these valves are crimped down onto a balloon, and that allows us to put it through a very small incision in the artery in the leg more than 95% of the time. So this is truly a remarkable shift from traditional open heart surgery. We manipulate this device over a wire. We do this under X-ray in the cath lab, and we carefully go around the aorta, which is the main artery that leads from the heart, and we very carefully position this valve gently through the diseased valve. So we're not taking away your current valve, but simply placing a new valve within it. And you'll see from this animation, the valve is aligned and it's centered, and we take great care to make sure it's in the right spot. And then what we do is we actually expand this valve after we've found ourselves in the right position, and it expands with a balloon, and you'll see the balloon going up shortly. As the balloon expands, this new valve opens up, and in place of the old valve, which has been crushed to the side, you basically now have a brand new functioning valve. Now, these valves are made of a very thin metal frame, and the tissue on them is actually made from heart tissue from either a pig or a cow, depending on the type of valve. We pull the device out, and what you're left with is this tube, which is then pulled out. We simply cinch down a suture to close up that little incision in the groin. We pull out the wire, and you're left with this brand new valve, as good as the day you were born, sitting in there well anchored. And if you remember that picture I showed you, the disease versus the normal valve, you can appreciate that this is a perfectly normal valve. It's not calcified, and it's opening and closing freely. You can imagine that we apply this to all 4 valves for any disease state, whether it's a narrowed valve or a leaking valve. And we have a myriad of different valves we can use depending on the valve state. One of the advantages of coming to a place like Stanford is being a cutting-edge tertiary medical facility. We have access to the latest and greatest in terms of devices, both in terms of devices that are available now, as well as devices that are not available to others, but are available to us as part of clinical trials. Finally, I'll touch on one more common condition, which is a valve condition, and that's mitral regurgitation, or a leaking mitral valve, which is also a very common pathology. Once again, open heart surgery to either repair or replace the valve was traditionally the only modality of choice. Unfortunately, in a group of patients, such as those with heart failure who have a leaking valve, they were at very high risk to have open heart surgery. And so those patients either underwent very high risk surgery or were treated with medications. So this is what a normal heart looks like. That's the blood returning to the left atrium up here from the lungs full of oxygen, passing through the mitral valve to the left ventricle, which then squeezes out the blood full of oxygen through the aorta, allowing it to pass to the rest of the body. So what happens is, over time, as a result of a number of risk factors, whether it's coronary artery disease arising from high blood pressure, high cholesterol, diabetes, or family history, that valve can become diseased, or simply because of age-related degeneration, or because of previous radiation or certain medications. Regardless of the cause, ultimately that valve can itself become degenerated, or the heart muscle can start to stretch and pull on that valve. And what happens is, you can see here in the animation, blood starts to leak backwards, which means instead of all of that oxygen-rich blood going forward into the rest of the body, some of it, and it becomes a problem when a lot of it is going backwards. So the heart's rendered inefficient. And you can see here, these leaflets are not coming together nicely. And so traditionally with surgery, they would do an incision in your chest, they would open up the heart, they would go in there, they would resect a piece of the abnormal leaflet, stitch it in together, and repair the valve. Or if they were unable to repair the valve, they would put a new mitral valve in there and replace the valve, either with a tissue valve or with a mechanical valve, a metal valve that required a patient to be on blood thinners for life. Now, fortunately, this device called the mitral clip was developed. Similar to the transcatheter aortic valve for aortic valve disease, the mitral clip represents a huge step forward in the ability to treat patients who have mitral regurgitation or a leaking mitral valve in a minimally invasive fashion. This procedure is done under general anesthesia through a vein in the leg, again, a small incision less than 1/3 of an inch. We pass a wire through a small hole in the heart from the right side to the left side, because the mitral valve is on the left side. We poke this hole, very small hole across, and then through this hole, we actually deliver this little clip device. And you'll see from the animation that the clip device is very elegant in its design. We do all of this just under X-ray in the catheterization laboratory, just the same place where you would have a regular coronary angiogram. We steer this clip down to that abnormal valve. We orientate it in different ways. So it's almost like a robotic procedure, but we're doing it via human hands, not via robot. We place the clip over where we think the leak is coming from, and then we advance the clip slowly and carefully, and this is done under echo guidance with a TEE, so that's an esophageal probe that's down while you're asleep, as well as the X-ray screen in front of us. We then try and grab those leaflets and bring them together. And what we're trying to do is reduce that leak by bringing the leaflets together. And we're basically emulating what the surgeons do, except in a minimally invasive, non-open heart procedure. And you can see there, we place the clip in a place where we try and reduce the leak. If we don't like it, we can release it and try again. And we do that as many times as needed to make sure we have a perfect result. This is a highly experienced operator-based procedure, meaning if you're considering having this procedure done, you can see on the left the regurgitation on the leaks being eliminated compared to where you started. This procedure is heavily dependent on expertise. And so I would encourage you for any procedure, but especially a procedure like this, to seek out a center and an operator who has a lot of volume of experience. So I will stop there. This is just a picture of our brand new state-of-the-art hospital in Stanford that's been open since last November. All of our structural heart procedures, or the procedures that I just showed you, are performed in this brand new state-of-the-art hospital. Every room is a single room. This hospital had a $2 billion construction, and I can tell you that it resembles the interior of a 5-star hotel. At least that's how the patients feel. And so it's really been a pleasure to work there and to welcome patients into such a wonderful facility. And I thank you all for your time.